The sulfonamides did not come from a natural source, so they are not true antibiotics. They are antibacterials, antiprotozoals, antimicrobial agents, but they are not antibiotics. For you to be an antibiotic agent, it means your original source must be a natural living organism. So sulfonamides all came from Prontosil, which was a dye that was synthesized way back when in Germany and was found to inhibit the growth of microorganisms. So that's their source, Prontosil. And they are, they inhibit the growth, but they are not bactericidal, so they are bacteriostatic. So they are bacteriostatic. And some of the derivatives of that Prontosil were found to inhibit certain organisms, particularly gram-negative organisms. Okay, so they're very good for gram-negative organisms, but they affect so many other agents that we say they have a broad spectrum. Okay. They affect many. They're very good for gram-negatives, but they also affect so many other organisms. And we'll find out as we go along. Okay. And the ones that are used clinically are the ones that are listed from number 1 down to number 12. And the one that we will take as the representative agent will be your sulfamethoxazole. Okay. So if we look at the mechanism of action of the sulfonamides, we see that it starts with the combination of pteridine with para-aminobenzoic acid. Mammalian cells can take up fatty acids, like folic acid, that's the Fa, folic acid, from diet or from the environment. Microorganisms cannot, so they have to synthesize their folic acid from scratch. And that synthesis follows this pathway. Pteridine with para-aminobenzoic acid in the presence of folic acid synthetase, that's the FAS, folic acid synthetase, will form folic acid. Folic acid is also sometimes called pteroic acid. So pteroic acid is folic acid. Okay. And so once that folic acid is formed, the folic acid will react with some glutamate to give you dihydrofolate or dihydrofolic acid. Okay. And then the dihydrofolic acid will be reduced by the enzyme dihydrofolate reductase to give you tetrahydrofolic acid, and the tetrahydrofolic acid will form cofactors. It will serve as a cofactor for the synthesis of your RNA, DNA, and proteins. So the sulfonamides will work right there at the inhibition of folic acid synthetase. So if you inhibit that synthesis, then you will not form folic acid. So that's the mechanism of action of all your sulfonamides. Now, we see that this enzyme, dihydrofolic reductase, can also play a role in the actions of some sulfonamides, because when you combine a sulfonamide like sulfur methoxazole with trimethoprim, you will get Bactrim, and that of course is used clinically to manage some infections. So the mechanism of action of sulfur methoxazole by itself will be to inhibit folic acid synthesis. But the mechanism of action of Bactrim will be the inhibition of both folic acid synthase and your dihydrofolic reductase. Okay, so let me say that again. Sulfur methoxazole by itself, its mechanism of action will just be inhibition of FAS. But in most cases, your sulfur methoxazole comes combined already with trimethoprim. And so the mechanism of action of Bactrim will be the inhibition of both FAS and DHFR. Okay. Now, there are other compounds that inhibit dihydrofolic reductase, and those are your pyrimethamine, proguanil, and cycloguanil. Proguanil and cycloguanil are actually used for malaria management. And proguanil is actually a precursor for your cycloguanil. In other words, 2C19 will convert your proguanil to cycloguanil. Now, we'll say that there are some other combinations that are associated with that inhibition of DHFR. Pyrimethamine, if you combine it with dapsone, it will give you maloprim. And maloprim is used to manage malaria. Okay? And pyrimethamine, if you combine it with sulfadoxine, that will give you Fansidar. And Fansidar is also an anti-malarial product. And then, of course, proguanil, if you combine it with atovaquone, will give you Malaron. And Malaron is also used for malaria. Okay. Now, dapsone by itself can be used for malaria, and it can also be used for leprosy, which is Hansen's disease. So it can be used for malaria, it can also be used for treating leprosy, and it can also be used topically for the treatment of some skin infections. Okay. And the product that is normally used for that type of herpetiform dermatitis, it's a special type. the brand name has been removed from market, but you can just see it as Dapsone on the market. So you can use your Dapsone for that. And the mechanism of action of Dapsone is just like the mechanism of action of your sulfonamides, because in terms of the structure, Dapsone is actually a sulfonamide, so it works also by inhibiting your FAS. And if you look at proguanil plus atovaquone, the proguanil will inhibit dihydrofolate reductase, and your atovaquone will inhibit the electron transport system in the organism, ETS, electron transport system. Actually, what it does is to inhibit cytochrome BC1. It inhibits cytochrome BC1, and when you inhibit that cytochrome BC1 in the electron transport system, you would actually cause a collapse of the membrane potential. Membrane potential in that organism. And so no energy will be generated in the mitochondria, and the organism will then die. Okay. So it would inhibit the cytochrome BC1 in the electron transport system, and that will lead to a collapse of the membrane potential in the organism. So in the mitochondria, there will be no energy generated, so the organism can then die. That's the mechanism of action of atovaquone, and by itself, it can be used in malaria. In combination with proguanil, it can also be used in treating malaria. Okay. So we know the mechanism of action of your sulfonamides. That's inhibition. Okay. So what do we know about the ADME of your sulfonamides using sulfur methoxazole as the representative agent? Okay. We know that sulfur methoxazole usually comes combined with your trimethoprim and Bactrim DS. Okay. That combination is always a 5-to-1 ratio. Always a 5-to-1 ratio. So in the double strength, that is Bactrim DS, you have 800 milligrams to 160 milligrams. Okay. So the trimethoprim is 160, the sulfur methoxazole is 800. That's in your Bactrim DS. There is a Bactrim single dose, which is just 400 to 80. So if it's not double strength, if it's just single strength, so that will be 400 to 80, because if you multiply 80 by 5, you will get that 400. So that's the ratio it normally comes in. All right, so in terms of the absorption of sulfur methoxazole, okay, because sulfur methoxazole comes by itself. You can see it under the brand name Gantanol. It comes as Gantanol, but most often, 99% of the time, is the Bactrim DS that is used. But sulfur methoxazole by itself is Gantanol. Okay. And if we look at the absorption for sulfur methoxazole, of course, we know that it can be administered. That's the route of administration. It can be administered orally, and it can also be administered intravenously. And there's a 1-to-1 ratio between the PO and the injectable. Okay, so if the patient was on the injectable form, that is the IV, when they leave the hospital and go back home, you just continue with the same strength, because it's a 1-to-1 ratio in terms of your injectable to your PO. So you don't need to change the strength or anything. So that's in terms of the administration. In terms of the distribution, your sulfur methoxazole gets broadly or widely distributed. It can get into the CSF. It can also get into the synovial fluid. It can also get into the placenta. And so it gets broadly distributed to the ocular, that is into the eyes, so it gets into major body fluids. The metabolism is primarily through N-acetylation. And it can also undergo those uronidation or glucuronide transfers. So it can use glucuronide for its biotransformation. Now, there are two major things to draw from that metabolism. One is that any drug that undergoes acetylation means that it utilizes an acetylase to complete that biotransformation. And whenever acetylase is involved, you know, that means there is a genetic component to the biotransformation of that drug, because you have your fast and slow acetylators. In other words, you can divide the whole world into just two populations: those that are fast acetylators, and those that are slow acetylators. Okay, Individuals who are fast acetylators, when you are using a sulfonamide, it will mean they will require a higher dose, okay, just to get to your normal therapeutic range. And individuals who are slow acetylators, it will mean that you will need a low dose so that they don't accumulate and go to toxicity. So there is a genetic component to the metabolism of your sulfamethoxazole, in the sense of the fast versus slow acetylators. So that's one thing we can draw from it. The other thing is that many drugs that undergo acetylation also tend to somehow produce or have a lupus-like side effect. So we can put this up here so that when we start talking about the adverse effects of those drugs, you see a lupus-like reaction. Some people call it lupus flare. So you see that in drugs that undergo acetylation. How does procainamide get biotransformed in the body when you're doing cardiovascular pharmacology? Okay. How do you classify procainamide? Okay. What are examples of your antiarrhythmic agents? Which one? Which one? Okay. Procainamide is one, right? You know, lidocaine, procainamide. And what's the difference in the classification of those two? How many classes do you break your antiarrhythmic agents into? All right. Okay, you always have antiarrhythmic agents classes 1, 2, 3, and 4. All your class 2 agents are what? All your class 2 agents are beta blockers. All your class 4 agents are what? Calcium channel blockers. Okay? And your class 1s are subdivided into A, B, C. And so procainamide is a class 1A agent, whereas lidocaine is a class 1B agent. Okay? But anyway, so your class 1 agent, that's procainamide, is biotransformed through this N-acetylation. And that's how you got NAPA, N-acetyl procainamide. You know, if you N-acetyl procainamide, NAPA, and NAPA itself is available as a drug. Okay. And if you look at the adverse effects of procainamide, since it undergoes that N-acetylation, you will see this. One of its adverse effects is lupus flare or lupus-like reaction. And that goes with many agents that undergo acetylation. Dapsone, the one that we mentioned here, that drug, because of its sulfonamide structure, it undergoes N-acetylation, and one of its adverse effects is lupus-like flare. So we have many examples that we can cite, but so that's what we wanted to draw out of that. And in terms of the glucuronidase transferase or glucuronidation, how does your bilirubin get biotransformed? Bilirubin undergoes what? Okay, bilirubin undergoes glucuronidation. Okay, and bilirubin will use the same substance for its own glucuronidation. Okay, and so if you give Bactrim, or if you give sulfamethoxazole, then it would compete with bilirubin for the substance that it needs for glucuronidation. Okay, and so in that situation, if the Bactrim is using up all the glucuronidase that you need for glucuronidation, then it will mean that what you will get would be an increase in unconjugated bilirubin, that is unmetabolized bilirubin, because the sulfonamide, in this case Bactrim or sulfamethoxazole, is using up all the substrates, all the things that bilirubin needs to be conjugated. So most of the bilirubin that will be circulating in the body will remain unconjugated. And if you have an accumulation of unconjugated bilirubin, what does it do? It goes to the brain. It goes to the CNS. And when it goes to the CNS, it causes problems over there. And that is called kernicterus. That's what will result. In other words, if you have or we can define it this way, kernicterus is actually a CNS damage or pathology that results from an accumulation of unconjugated bilirubin. Okay. And that, as we shall see, is one of the adverse effects of your sulfonamides. That is usually seen in babies, children. If you give a toddler or a baby that is still undergoing nursing, if you use Bactrim or sulfonamide in that patient, you're more likely to actually produce kernicterus in that child. And how would you know that they're experiencing that elevation of unconjugated bilirubin? In other words, what are the signs and symptoms of kernicterus? Okay. That baby would not be feeding properly. That is, would not be accepting the milk or whatever you're giving them. They will not be feeding properly. And that baby would cry all the time. And the crying will be of a high-pitched nature. High-pitched crying. They will be restless. They will have fever that fluid that will develop. Their muscle tone will go down, so you'll have muscle weakness. They will get muscle weakness, lack of energy, reduced energy in that little child. And then you can see spasms, muscle spasms in that little child. So, but the crying, the high-pitched crying, they will not take their food or like to be fed. And then the yellowing of the skin. So those are very obvious things that you can see in a child that is developing that crown icterus. And so you don't want to use a sulfonamide in a little child because of fear of crown icterus. And that's why we say that a contraindication of your sulfonamides is pregnancy at birth or at term. Pregnancy at term, you don't want to use a sulfonamide, especially if the mother is going to be breastfeeding. So those are some things we can draw from the metabolism of your sulfonamides. That's distribution, okay. In terms of the half-life for your sulfamethoxazole, the half-life is about 8 to 10 hours. About 8 to 10 hours, and that's why you see it usually given on a BID basis. It's usually administered on a BID basis. There's one situation when you will give Bactrim on a QID basis. And that situation is PCP. If you're using Bactrim to treat, pneumocystis carinii pneumonia, it is administered on a QID basis. And what you do is you calculate the total daily amount, and then you just divide it into 4 equal parts. And you use the trimethoprim strength, not the sulfamethoxazole strength. Okay, so and you use that 15 to 20 milligrams per kilogram of body weight, okay, of the trimethoprim. And you calculate what is needed for the whole day, and then you divide it into 4 equal parts. That's the way it is used in the treatment of PCP, especially in AIDS patients. So that's the half-life. And if we look at the plasma protein binding, that is about 70%. Okay. And that is the source of drug-to-drug interactions involving Bactrim or sulfamethoxazole. And we'll see some of the drugs that interact with it because of that plasma protein binding. If we look at the excretion of Bactrim, of course, it is primarily renal in terms of the excretion. Okay. It basically undergoes glomerular filtration and may also undergo some secretion. Okay, so that's the ADME for your bacterium. Okay. Because the renal system is the main, route of excretion, it somehow, or it can form crystals in the urinary tract system. And that cuts across the board for all sulfonamides. You're always worried about crystals forming in the urine, which is the reason why you advise the patients to take your sulfonamides with plenty of water so that you can prevent that crystallization in the renal system. Okay. So before we get to the indications, we can look at some of the adverse effects of your bacterium or sulfamethoxazole. Anytime you have a sulfonamide, you always talk about the triple H and US, US. Okay. The first H is your hematologic adverse effects. And those can include, the manifestations can include anemia, and your thrombocytopenia, and agranulocytosis. And the anemia can be either aplastic anemia, because you're having a decrease in your folic acid production. So it can be aplastic anemia, or it can be hemorrhagic anemia. And then, of course, you can see a positive Coombs test with your sulfonamide. That is, the sulfonamide can be acting as an antigen, and the antigen can cause the production of antibodies on your red blood cells, and so the antigen-antibody reaction can then take place on your red blood cell. That's positive Coombs test. And sometimes it can lead to the breakage of the red blood cells, and sometimes it's not strong enough to break the red blood cells. Okay. So you can see those hematologic adverse effects. And the other H will be hepatic. And in the case of bacterium, this is not frequently observed. In other words, it does not have a high liver damage type thing. So it's very minor and it does not occur frequently. And then The other H is your hypersensitivity. Hypersensitivity reaction. And with, Bactrim or sulfamethoxazole, the manifestations can include your Stevens-Johnson syndrome, SJS, can be bad enough to cause TENS, toxic epidermal necrolysis, okay, and it can be just serum sickness. Serum sickness. What type of hypersensitivity is that? You have your types 1, 2, 3, and 4. Serum sickness is type what? Type 3. Okay. Type 3. Serum sickness. And you can say drug fever that may also be produced as a manifestation of hypersensitivity. And then the usual things, rash, itching, and all that. Can be bad enough to go to anaphylactic shock. Okay. So all of those can be manifestations. And the U, of course, is urinary tract manifestations, and those are just usually in form of crystals forming in the urine, and that's why you take it with plenty of water. It can be bad enough to cause tubular necrosis. And if you have tubular necrosis, that can result in death. So this may be deadly. Or it may just simply affect the glomerular filtration. Yeah. But it may also cause necrosis of the tubules. So that is that, and then the S, of course, will be skin. Okay. And that can simply be not this severe ones that you see with hypersensitivity. So that can just be skin reactions, that is rash, itching, hives, things like that on the skin. And it may also include photosensitivity. So that's why you advise the patient not to expose themselves to too much sunlight. So you can see all of those. So those are common to all sulfonamides, the triple H and OS. You see that with almost any sulfonamide. And other adverse effects, as we've mentioned before, lupus-like flare or lupus-like reaction, and possible kernicterus. Okay. And then you can see some CNS-like adverse effects with your Bactrim. You can see some hallucination. Hallucination can occur, of course, because the patient may have some headaches and may experience some dizziness. That can happen in certain individuals. So you may also see some peripheral disorder, peripheral you can see some peripheral pathology or pathological conditions. And you can see optic neuritis, the neuritis. Optic neuritis, you will see peripheral neuritis also as part of the peripheral pathology that can occur. So those are some of the CNS related adverse effects that one can see with your sulfonamides. Okay. We can put some non-specific ones there. Well, I already put it. The headache that is seen. So those are essentially the adverse effects of your sulfonamides. In some individuals who are very sensitive to sulfonamides, they may experience some vertigo, you know. So that, well, we're not listing them. Okay. They may experience some vertigo. The room would seem like it's spinning around. And insomnia may also be present. So those are the other two that can usually be associated with the central nervous system also. But anyway, those are the adverse effects that one can observe with your sulfonamides. So now we can look at the indications. And maybe we should list the indications first and then come back and discuss some of them. Those that we want to touch today. Okay. Can be used to prevent colonization of burnt tissues by gram-negative organisms. Okay. So that will be one. It can be used to manage brucellosis. you know, the different strains of Brucella, you know, Brucella abortus, Brucella melitensis, and so on, Brucella suis. Okay, so can be used for that. Now, you can use a sulfonamide for bowel cleansing. Okay. We may have to remove that eventually, because the main sulfonamide that is used for that bowel cleansing is sulfatalidine. Sulfatalidine, the last one that I listed here, number 12, sulfatalidine. Because that drug is going off the market. That's why I said that we might have to remove it. So in that case, neomycin will still suffice for bowel cleansing. But the sulfonamide of choice for bowel cleansing is sulfatalidine. It's basically on its way out. Urinary tract infection, ulcerative colitis. That would be another indication, and we'll come back to deal with all of them. Let's try this. Okay. STDs. And for STDs, we're talking about vaginitis. That's one. Chancroid. That's another. Okay. Chlamydia infections. And in that situation, we're talking about only your trachomatis. Chlamydia trachomatis in particular. Okay. Granuloma inguinal. And that's the one that is now referred to as donovanosis. That's your donovanosis. And we'll put in here for your vaginitis, because you can get one that is due to Candida, Candida albicans, and one that is due to bacteria or Gardnerella. Gardnerella vaginitis. Okay. So we'll come back to your STDs. Number 7, skin conditions. So those would be like your psoriasis, including your acne, including rosacea. Seborrhea. Anyway, so we'll come back to that. just sinusitis. Another one, shigellosis. Salmonella infections. Travelers, like travelers diarrhea. Include acute gastroenteritis or age. Acute gastroenteritis. That's your food poisoning. Food poisoning. Use it for that. Also, that's 12. 13. Otitis media. That's another one. Okay. And we can talk about PCP or pneumocystis carinii pneumonia. We can talk about your just regular pneumonia that is caused by a bacterium. Malaria, another possible indication. Toxoplasmosis. Another indication. And we can talk about Yersiniosis. Yersinia infection by Yersinia enterocolitica. Not your pestis, which we call plague. Okay, so Yersinia enterocolitica infections. You can talk about Legionnaire's disease. Use it for those. So you have several indications. Okay. I'll put another one that's, we'll put slash for this number 5. We'll put, say, number 20. Arthritis. That will relate to that number 5. Okay. All right. So for burns, the sulfonamide preparation of choice is silver sulfadiazine. Silver sulfadiazine, and I'll put it somewhere right here. That SSD, silver sulfadiazine, you know. Sulfadiazine by itself, okay, can be administered orally. as a tablet. Okay, that's sulfadiazine. Can be administered orally, and that's what you actually use for toxoplasmosis. That number 17. Yeah, we can do that right away. So, toxoplasmosis, the sulfonamide of choice will be sulfadiazine right here when it's administered orally. But you have a topical agent, which is silver sulfadiazine. Okay, that's not administered for systemic purpose. That is to manage some burnt tissues, so that the burnt tissues will not be colonized by gram-negative organisms. Okay. So that's the sulfonamide of choice for that number 1 indication. Okay, so we can rub that off. The alternative, in other words, if you don't have SSD, what you can use is sulfamylon. Okay. Sulfamylon, number 10. Okay. That's sulfamylon. That's the alternative to SSD for burnt tissues. So that's what those are used for. For brucellosis, of course, it's Bactrim DS. Okay. Bactrim DS. Let's see. Well, we can rub that up. Bactrim DS, we already know the organisms that are responsible for brucellosis. And for bowel cleansing, sulfathalidine, we've mentioned that, will be the sulfonamide preparation of choice, but it may not remain on the market for too long. Okay. For UTI, especially when the UTI is caused by E. coli or by Klebsiella or by Enterobacter. Okay, so the sulfonamide of choice will be Bactrim DS. It used to be sulfasalazine, but that was taken off the market. So for UTI, would still be Bactrim DS as the sulfonamide of choice. Now, this drug, sulfamethoxazole, that's the only thing it is used for, urinary tract infection. That's its only indication. So you can see that used. Ulcerative colitis, the sulfonamide of choice will be sulfasalazine. This number 12 here. No. Sulfasalazine. Okay, number 8. Sulfasalazine. Sulfasalazine is not well absorbed. It is usually not even given to be absorbed into the system. When you use sulfasalazine, it will be broken down to sulfapyridine and amino salicylic acid, not acetyl, not aspirin. Aspirin is acetyl salicylic acid, but this is amino salicylic acid that it is broken down into. And we mentioned that it is not well absorbed, so you don't want it to really be absorbed, and that's why you use it for ulcerative colitis. so that it can stay in the colon and do its work. But that ASA part can help with this inflammation in the colon. Okay, so that's one indication for your sulfasalazine, which is azofidine. And we know that it can also be used for arthritis. And that's why I said that number will be related to arthritis. Okay. So the sulfonamide of choice here would be sulfasalazine, or azofidine. That's the brand name. You have azofidine regular, and you have azofidine EN, that is enteric, which sort of protects the lining of the stomach. So for ulcerative colitis, azofidine, and for arthritis, it would be azofidine also. Okay. STDs, all right. For vaginitis, vaginitis can be caused either by yeast, Candida albicans, that's a fungus, or it can be caused by a bacterium like Gardnerella. Gardnerella used to be called Haemophilus. It used to be called Haemophilus vaginitis, but now it's called Gardnerella vaginitis. If it's caused by fungus, that is Candida or the yeast, the sulfonamide of choice is a product that is called ABC, ABC vaginal cream. Okay. And that ABC vaginal cream is sulfanilamide. This one, number 4. That's your ABC, sulfanilamide. So if it's fungus, it will be sulfanilamide that you would use. But if it's Gardnerella, if it's bacterial, if vaginitis, what you will use is called triple sulfur. You can see it under the brand name Saltrin, or the generic name triple sulfur vaginal cream, which basically means it has 3 sulfur drugs in it. One is sulfacetamide, 2 is sulfathiazole, and 3 is sulfabenzamide. Okay. So you say sulfacetamide, and that drug is just used topically. Sulfacetamide can be used for the eyes, and it can be used for vaginal infections, and it can also be used for skin reactions. Okay. It's just used topically only, but so triple sulfur, sulfacetamide, sulfabenzamide, that's number 5 there, and sulfathiazole. Okay. Maybe I should do this. Numbers 1, 2, and 3 are short-acting sulfur drugs. Numbers 4 to 8 are intermediate acting sulfur drugs. Okay. And number 9 is ultra long acting sulfur. Then the ones below are mainly not for absorption. So that's what we have for your bacterial vaginitis. So the sulfur preparation of choice will be Saltrin, which is triple sulfur. Okay. And apart from vaginitis, you can say chancroid. Chancroid used to be sulfasalazole, but that's been removed from the market. So now the sulfonamide preparation of choice will be Bactrim for your chancroid. And that's caused by Haemophilus ducreyi. I was saying before, Haemophilus ducreyi causes chancroid. Chlamydial infections. In this case, Bactrim is the drug of choice. Sulfacetamide. Sulfacetamide, which is the very first one listed there. Sulfacetamide will be for your chlamydia trachomatis infections. So chlamydia trachomatis, as we've discussed before, can cause trachoma, which is a very serious eye infection and can lead to blindness. Okay. And it can cause inclusion conjunctivitis. Inclusion conjunctivitis, an eye infection, which is not as serious as trachoma. Okay. But it can also cause or produce cough, cervicitis, urethritis, proctitis. Okay. Cervicitis, urethritis, and proctitis can produce all of those, and it can cause lymphogranuloma venereum, lymphogranuloma venereum, LGV. That's another STD that your chlamydia trachomatis can cause. And so when it causes, these eye conditions, then the sulfonamide preparation of choice would be that sulfacetamide. Okay, sulfacetamide, remember, it is only used topically, mainly, that is in the eyes and vaginal tissues, things like that. So for chlamydia trachomatis infections, we'll say sulfacetamide will be the sulfonamide preparation of choice. GI, granuloma inguinal. Okay, so you would use Bactrim as the preparation of choice in that situation. So that takes care of your STDs. And you notice that we did not mention gonorrhea because there are many species of Neisseria gonorrhoeae that have developed resistance to your sulfonamide preparation. and the resistance to bacteria, resistance to your sulfonamides by bacteria usually takes place through three different mechanisms. You can have resistance that develops because the bacterium changes its genome such that it actually utilizes the drug that you are administering. See, that's a very strong relationship, structural relationship between your para-aminobenzoic acid and your sulfonamide. So the bacterium can very easily adapt to the use of your sulfonamides instead of para-aminobenzoic acid. So that's one way by which it can become resistant to the effects of the drug. It may also produce a FAS. Have we rubbed it off? Okay. It may produce that synthesis that is that has very, very low affinity for your drug. You know, your sulfonamide has to bind to that FAS to inhibit it. And so if the affinity is reduced, it will not be able to bind. And if the drug does not bind to FAS, it cannot inhibit FAS. You know, and then number three, your organism can actually produce an increase in para-aminobenzoic acid. So if you have a bunch of PABA, the PABA will now overwhelm the inhibition caused by your drug because it's a competitive type inhibition. If you increase one of the reactants, you decrease the effect of the other. Okay, so those are three mechanisms by which resistance can occur to your sulfonamides, and that seems to be happening a lot with Neisseria gonorrhea. That's why we didn't mention gonorrhea as an indication. Let me skip 7 for the time being. Sinusitis, that will be Bactrim. The sulfonamide preparation of choice will be Bactrim. Upper respiratory tract infections, especially when caused by, strep. You can use your Bactrim. And even when it is caused by H flu, it would even be more effective when the sinusitis is caused by H flu, because H flu is gram-negative. Your sulfonamides are very good against gram-negative organisms, so it can be used there. Against shigellosis, Shigella can cause dysentery. Okay? And so if Shigella causes dysentery, one can use Bactrim to manage that. Shigella can also cause food poisoning. So if you're talking about your acute gastroenteritis, you can use Bactrim. If that age is caused by Shigella, so it can be used there. Salmonella. For Salmonella, of course, you are talking about conditions like your typhoid. Typhoid is caused by Salmonella typhosa. So you can use it to treat that. And of course, salmonella can also produce your food poisoning. We can use Bactrim for the treatment of that age or some acute gastroenteritis. Traveler's diarrhea, that is usually due to E. coli. Okay, so for that treatment, you can again use your Bactrim as the sulfonamide of choice. And we've mentioned age several times, so you know it will be Bactrim for those also. Okay. Otitis media, it used to be sulfasalazole. Sulfasalazole is gone, so Bactrim will be the sulfonamide of choice. And of course, you know that otitis media can be caused by your H flu, and it can be caused by Bronchomila. Bronchomila catarrhalis can also cause your otitis media. Okay. PCP, pneumocystis carinii pneumonia. Of course, one can use pyrimethamine and your primaquine with a sulfonamide, and the sulfonamide that we can take as the sulfonamide of choice in such a situation can be either your sulfamethoxazole, which is not too great in that situation, but this drug, sulfadiazine, can be very effective in your PCP, okay, in your PCP. So those will be the top two. And then pneumonia that is not due to this PCP, that is like streptococcal pneumonia, you can also use your Bactrim in that situation. Okay. Don't forget the QID dosing in your PCP that we discussed earlier. Okay. Malaria, of course, the sulfonamide of choice will be sulfadoxine. Okay. Sulfadoxine. This one, number 9. And you see I had it there by itself because sulfadoxine is an ultra-long-acting sulfonamide. Its half-life is in days, like 9 days. So ultra-long-acting sulfonamide. That's the one that you use for malaria. Toxoplasmosis. You would use, you can use that sulfadiazine right there, sulfadiazine as the main sulfonamide preparation that you can use in toxoplasmosis. Okay. And that can be given with your pyrimethamine in toxoplasmosis infections. Yersinia, Yersinia enterocolytica. Okay, Bactrim is not really good against Yersinia pestis, which causes plague. So Yersinia can cause yersiniosis, and it can also cause sepsis. So in that situation, one can use Bactrim. And then in Legionnaire's disease, it would also be Bactrim for that. And that's caused by Legionella, one of your Ella sisters. Legionella, like Legionella pittsburghensis, because it was first discovered in Pittsburgh, Pennsylvania. So Legionella pittsburghensis, Legionella pneumophilia, because it causes pneumonia. Okay. So it can be you can use Bactrim for that. Cholera, that is caused by Vibrio cholerae, responds to sulfonamides. It used to be sulfoxazole as the preferred agent, but now you have to go with Bactrim for the management of cholera. Cholera caused by Vibrio cholerae. And then you have this parasitic condition, that is caused by a parasite. The parasite is called Cyclospora. Cyclosporosis is often attained or incurred when you use or when you take contaminated cilantro. So that food, cilantro, is usually the source of infections with Cyclospora, Cyclospora cathayensis. But anyway, this parasite usually comes from eating contaminated cilantro. And the only antibacterial that actually works against that Cyclospora is Bactrim. Anything else is below par, so it's just Bactrim that you use for cyclosporosis. If you eat cilantro and you suddenly start to get feverish and you have abdominal pain and you see abdominal distension and you're having some diarrhea, but diarrhea is usually the first sign that you'll get with cyclosporosis. So diarrhea and then abdominal distension, abdominal pain, flatulence and fatigue, all those come together as manifestations of that cyclosporosis. And you better get on Bactrim DS immediately, so it can clear that condition up for you. Okay. Now, the last thing we said would be the skin. So for the skin, these are the conditions we're talking about. You know, all the psoriasis, acne, rosacea, and seborrhea. And the sulfonamide preparation of choice will be something that contains that sulfacetamide. Okay. Sulfacetamide. And you can see preparations that would have sulfacetamide alone. Okay. Alone, or sulfacetamide plus sulfur. The ones that will have sulfacetamide alone will be Rosula NS, and the NS simply means non-sulfur. That is, there's no sulfur in, you know, because there is a plain Rosula, which means Rosula plus, sulfacetamide plus sulfur. Okay. This one is without sulfur, that is no sulfur. Okay. So Sebizon has been taken off the market. It is still listed over here. And for there. And then Claron, which is the main one that remains under this group. Claron, that's your sulfacetamide without sulfur. Okay. And the ones that contains, you know, sulfur, you can say Sumaxin. And I always mention that one should not confuse Sumaxin with Sumicin. Sumicin is actually a brand name for tetracycline hydrochloride, so it's totally different. This is tetracycline, this is sulfacetamide plus sulfur. Okay. So Sumaxin is still available, Ava is still available, Plexion, and Nicocin. So these are all still present or still available on the market. That is your sulfacetamide plus that's your sulfur. I put Bleften. I hope I did. Okay, I did not. That sulfacetamide can be seen by itself under the brand name Blef-10. Okay. Sulfacetamide, that's one of its brand names. And Blef-10 is used for eye infections. Okay. So That's why I said that sulfacetamide is just used topically. It's either vaginal or optic, in which case it would be left-hand, or it can be used like an inunction for skin infections. All right. What essentially all we want to cover. That's for indications. And drug-to-drug interactions. We've mentioned some of them. Sulfonamide can be synergized by your trimethoprim. That's what you have in Bactrim. You know, sulfonamide, sulfamethoxazole being synergized by trimethoprim. That's that combination. Or what you call sequential activation. You know, in other words, the sulfamethoxazole walks over here, and then the trimethoprim walks over here. So sequential, after the FAS, then the DHFR, the hydrofolate reductase. So that's sequential activation, and that, of course, gives you an increase in effect. So that's one, sequential activation, okay, or synergism. Then the other, of course, would be a local anesthetic. Okay. A local anesthetic being administered with a sulfonamide. The local anesthetic will be converted in the body to PABA. So you're generating more PABA. And if you have more PABA, then you have a decreased effect of your sulfonamide. Okay? So that would be antagonism. Okay? So the local anesthetics can antagonize your sulfonamide because of their generation of para-aminobenzoic acid. So that's another point of interaction. And the sulfonamide, that is the Bactrim or sulfonamide preparation, okay. The sulfamethoxazole may actually displace, okay, may actually displace some drugs from plasma protein binding sites. And those drugs, of course, can include indomethacin. That's one. Your aspirin also is another. Probenecid is another. So those are examples of drugs that can be displaced from the plasma protein binding site, which means you will get an increased effect of these drugs, because when they are displaced from the plasma protein binding sites, they're now available in the unbound form. And you know your drugs act in the unbound, that is the free. You will increase the amount of free drug that is available, and so they can lead to toxicity of these drugs. Okay. Now, there are some agents whose effect will be accentuated by sulfonamides. Okay. Your oral hypoglycemic agents, your oral anticoagulants, those can be accentuated in terms of their effects, and even you can also see an accentuation of some agents like, Schedule 1B drugs, or not Schedule 1, Class 1B drugs. By your probenecid, for instance, dilantin. So you can have that accentuation of effects. So that's another interaction. And you have some contraindications for your sulfonamides. One of them, of course, will be hyperbilirubinemia. In other words, if a patient has hyperbilirubinemia, you don't want to use a sulfonamide in such a patient. Why? Because kernicterus can occur, because you will have more unconjugated bilirubin, which can then go to the brain and cause that kernicterus. At term pregnancy, you don't want to use a sulfonamide in a patient who is about to deliver or close to delivery time. So, a patient that has glucose 6-phosphate dehydrogenase. Deficiency. A patient with glucose 6-phosphate dehydrogenase deficiency, if you give them Bactrim, you are increasing the likelihood of them having hemolytic anemia. So it has to be a contraindication. And then you don't want to use them concurrently with sulfonamide-based drugs, like the diuretics. your sulfonylureas. So your sulfonamide-based diuretics will be your thiazides, your furosemide, or high ceiling diuretics, Lasix, or your carbonic anhydrase inhibitors. So because those classes, thiazides, high ceiling diuretics, that is Lasix, furosemide, taptan, and your carbonic anhydrase inhibitors, those three have a sulfonamide base, so they're called sulfonamide diuretics, and so you will be enhancing whatever effect that they produce, and that may lead to more hypokalemia, and the hypokalemia can then affect cardiovascular functions and muscular functions, and things like that. And then, like your sulfonylureas, you will get a further decrease in plasma glucose, because that's what the sulfonylureas do. So that's what we have for the sulfonamides. And questions before we move on to fluoroquinolones. So the fluoroquinolones, generally just like the sulfonamides, are synthetic agents. So they didn't come from a natural source. So they're not antibiotics. They are antibacterials or antiprotozoals, but they're not antibiotics. So they were synthesized. Your fluoroquinolones were synthesized. Let me do this. The quinolones, when they were synthesized, they were non-fluoro. Okay, they didn't have fluoro, so they were only effective against gram-negative organisms. The original quinolone that first came to market was nalidixic acid. Its brand name was, Negram. And if you just switch that around, you say gram negative, So they concentrated in the renal tubule. That's why the only indication was urinary tract infections. Okay. But all of them have been basically discontinued. Okay. There was that oxalinic acid. There were only 3, but nalidixic acid was the first one that was made. Yeah. So all of them have been discontinued now because you have better drugs like your fluoroquinolones. But this was the original nalidixic acid. After this was when they added fluoro to the quinolone. Okay. And when you add the fluoro, you get an increased effect against Pseudomonas aeruginosa. See, that was the first major advantage we got from the quinolones. Adding the fluoro increased their spectrum of activity to Pseudomonas. And it also increased their activity to your gram-positive agents. It used to be only gram-negative, like you saw, gram-negative. Okay. So, and they had some piperazine added to their structure, and this led to even more increase in effectiveness against Pseudomonas aeruginosa. The piperazine group. Okay. So by adding the fluoro and by adding that piperazine structure, you got an increase to gram-positive organisms and also to Pseudomonas aeruginosa effectiveness. Now, and then of course, the usage increased, that is the spectrum of activity increased. It was no longer just urinary tract infections. Okay. Now, urinary tract infections is different from UTA. UTI is different from UTA. The A there is antiseptic. If you have an initial urinary tract infection, you are not supposed to use a UTA. Examples of UTA would include your nitrofurantoin, and would include your methenamine. When you look at this nitrofurantoin and methenamine, they are only supposed to be used when you have a recurrent urinary tract infection. Okay, the first time a patient has a UTI, this should not be the first drug used. And you see that a lot in practice. Somebody has UTI for the first time, they give them, you've seen some of them. You've seen this drug, macrobid. You know, they just place them on macrobid or macrodantin. Okay. Or firadantin. And that is essentially malpractice. Because these are UTAs. Use them for recurrent UTIs. Okay. Macrodantin, macrobid, those are the macrocrystals of firadantin. Okay. That is your nitrofurantoin. Those are the macrocrystals. But they are not interchangeable. Okay. Macrobid, as you can see from the name, is to be administered on a BID basis. Macrodantin is actually administered on a QID basis. Okay. Macrodantin, you can see as 100 milligram capsules, you can give it on a 4 times a day basis. And macrobid is twice a day. Because macrobid has a monohydrate salt. It's a monohydrate. And then it has some macrocrystalline. And it is like 25 to 75 percent. The macro is like 25, and the macro is like 25, and the monohydrate is about 75%. Whereas macrodantin is 100%, and it only has macrocrystals. So they're not the same, and they cannot be substituted for one another. Okay. So the thing that stands out about, nitrofurantoin, which is firadantin, this brand name, firadantin. Nitrofurantoin preparations can cause photosensitivity, and they should not be used in patients that are glucose 6-phosphate dehydrogenase deficient. You can get that hemolytic anemia in such situations. And you want to administer the nitrofurantoin with something that's acidic, a drink that is acidic, for instance, that can reduce the pH of the urinary tract. You can give them with ammonium chloride, for instance. That would lower the pH of your urinary tract. Cranberry juice. Cranberry juice will lower the pH of the urinary tract and increase the effectiveness of not just your nitrofurantoin preparations, even your methenamine preparations. So both of those UTAs require an acidic medium to work optimally. Okay. Methenamine, the same thing. You can use it with mandelic acid. You can use it with hippuric acid. When it's given with mandelic acid, it comes as mandelamine. That would be the drug, the brand name. And when you use it with hippuric acid, it will be hip rex. Okay. And this would be Mandela. And for Mandelamine or Hiprex to work optimally, okay, they would have to convert your methenamine to formaldehyde, and it is that formaldehyde that will then inhibit the growth of the bacterium. So you get conversion to formaldehyde. That conversion is optimized in an acidic medium. So that's why you always have to use either mandelic acid or hyperic acid or cranberry juice or ammonium chloride. Ammonium chloride to lower the pH in the urinary tract system for it to work optimally. We would, of course, all of these agents are given orally, so that's what we will say with the UTAs. And very often you have dysuria when the patient has urinary tract infection. They have pain in the urinary tract or dysuria. And that dysuria is most often managed with your peridium. And your peridium is peridium is, of course, tablets, and you always see 100 to 200 milligrams being given on the TID basis, and it's usually for about 3 to 5 days, no more than that, because you're just managing the dysuria that accompanied the urinary tract infection. And this is your phenazopyridine. You can see it in the generic name in the pharmacy. Okay, and the key is right here. It's an azo compound. And so even over the counter, you have that azo product that you can use for dysuria of urinary tract infection. And a major side effect of azo or phenazopyridine, phenazopyridine or pyridine, is discoloration of the urine. See, that azo compound would give you a reddish discoloration of the urine. So if you want to play on your bus at work, you can do that. I did that a few years ago. And we had a party at Getty Oil Research. That's where I was working back then. And there was this particular boss that nobody liked. And that was when we studied iridium in class. Okay, I won't tell the story. Okay. But I put some iridium in his drink, and he went to the restroom, he saw redness, he thought he was bleeding, so he ran out of the party. And then we enjoyed the rest of the day. But anyway, so now we're left with the fluoroquinolones, and those are the ones that I've listed here. And the one that we will take as the representative agent, of course, will be ciprofloxacin. So the quinolones are bactericidal. Okay? They're bactericidal, but they are not antibiotics. Okay? And they provide concentration-dependent bactericidal effect. Okay, the mechanism of action of Cipro, we'll take that as the representative agent. So they all tend to inhibit DNA gyrase. That is an enzyme that belongs to the topoisomerase group. Topoisomerase type 2. Okay. And that enzyme is needed for the DNA metabolism, that is, for the DNA to replicate itself. So it's needed for DNA replication. And all fluoroquinolones, that's the mechanism of action, all of them. In terms of the ADME, for Cipro, you have route of administration as usual, so you can give it orally and you can give it IV, and you have some other preparations, and you have ophthalmic preparations. For your ophthalmic preparations, you have siloxane, and siloxane you can also administer in the ear. Okay, whatever you can put in the eyes, you can also put in the ears. So you have the drops, that is the solution, and you have the ophthalmic ointment also that you can use. Okay. And for the headache, you have Cipro HC, which is Cipro with hydrocortisone. Okay. And then you have Cipro Dex, which is Cipro plus dexamethasone. And you have an agent that we call Autovel. Which is ciprofloxacin with fluocinolone. Okay. Okay. So that's for the ears. All of these are otics, these preparations. And then of course you have the IV and you have the tablet. That Cipro Cystis pack that has been removed from the market. There used to be a pack that you just take once, one time only if you have urinary tract infection, and you clear it up. But that was removed from the market, so that's what we have for the routes of administration. And when you give it with food, when you give it PO, you can administer it without regards to food. Okay. Many of the fluoroquinolones that are given orally, you will have to worry about food because food can cause a delay in absorption. But the overall amount that will be absorbed will not change. Okay, so you can give your Cipro without regards to food if you want to. Okay. However, it does interact with many things in terms of its absorption, like iron, zinc, Pepto-Bismol, your magnesium. So all of those can kill it or decrease its absorption from the GI tract. Okay. So the half-life for your Cipro is about 4 to 6 hours. However, you usually give it on a BID basis because its metabolite is also active. It has antibacterial activity. So that's why you can give it on a BID basis. There. The drug can inhibit it can inhibit 1A2, and through that inhibition it may interfere with the metabolism of tegretol. So it may inhibit the metabolism of tegretol because of that inhibition of A12. Okay. So the plasma protein binding it's about 20 to 40%. And so because of that low plasma protein binding, it is very extensive in terms of its distribution. So it can be distributed into the cerebrospinal fluid, because it has that low plasma protein binding. And the excretion is primarily renal. Okay. is primarily renal. About 70%, 70 to 75% of the amount that is excreted is excreted unchanged. Yeah. This excreted, and so that's the ADME for your Cipro. And in terms of the indications, okay, to better understand the indications, we can just take a quick look at a spectrum. Okay. Cipro is believed to be a broad spectrum agent. Okay. So staph and strep, it will be effective against both. So your gram-positive aerobic cocci, so it will be effective against both of those. And then it will be effective against your bacillus, that is the part of your club. Okay, CLB, so it's effective against Bacillus anthracis. Okay, and then you go down to the gram-negative aerobic cocci. Okay, so it is effective against Branhamilla, and it is effective against Neisseria species. Neisseria and Branhamilla. And so you go down to the gram-negative aerobic bacillus that are enteric. It is effective against all those enteric organisms. Gram-negative aerobic bacilli that are enteric. So all of them. And then against the non-enteric, it would also be effective against all of them, with the exception of your streptobacillus, like Streptobacillus moniliformis, the one for rat bite fever. It's not effective against that. It's not effective against Francisella. It's not effective against that. One of these should work. And it is not effective against Bordetella. That's the one that causes pertussis. Okay, whooping cough. So it's not effective against those. And if you look at Pseudomonas species, it is very good against all Pseudomonas species, with the exception of Pseudomonas malayi. So very effective against Pseudomonas. especially Pseudomonas aeruginosa, but it is not effective against your Pseudomonas malayi. Okay. It has been shown to actually work against Yersinia pestis, the one that causes plague. Okay. So, but it is right now just recommended for prophylaxis of plague, especially if the patient has, septic or septicemic, that would be better, septicemic plague, or if they have pneumonic plague. So it is just for prophylaxis in such situations. But it is also effective against Mycobacterium species. Okay. And it is also effective against rickettsia. Rickettsia species. And chlamydia is effective against chlamydia species. Okay, so that's in terms of spectrum, and we've seen its ADME. So we can go into its indications. You can use Cipro in many situations because it has that broad spectrum. Because it's effective against Mycobacterium, so it's effective in the management of tuberculosis, Mycobacterium tuberculosis, and it is effective in the management of Mycobacterium avium intracellulare complex, that you see in AIDS patients. Okay. Because it is very effective against Pseudomonas aeruginosa, it is very effective in treating external ear infections caused by Pseudomonas or caused by Staphylococcus. Okay, so it is very effective there. Cystic fibrosis. Okay. See, it is effective in the management of cystic fibrosis caused by those two organisms again, Pseudomonas aeruginosa and Staphylococcus aureus. Okay. So it's effective in those. And then, like we mentioned, plague, but mostly for prevention, for prophylaxis of plague, particularly prophylaxis of septicemic type of plague and pneumonic type of plague. So if you want to use a fluoroquinolone to treat plague, it will be moxifloxacin, that first one, moxifloxacin. That's the one you would used for management or treatment of septicemic or pneumonic plague. So that's an invitation there. Lower respiratory tract infections, very good in it. So if your patient has pneumonia, like your community acquired bacterial pneumonia, CABP, so it will be very effective there. Upper respiratory tract infections, like acute sinusitis. You know, Cipro would also work there. If we take the bones, okay, bone infections, Cipro works very well, especially when it's caused by, say, your staph. You know, when you have osteomyelitis caused by staph, you can use that. It works against bacillus, so which means you can use it to treat anthracis or anthrax. Bacillus anthracis causes anthrax. So Cipro is very effective in treating that. Infectious diarrhea. Infectious diarrhea. Especially when that infectious diarrhea is caused by Staphylococcus, by Salmonella, by Campylobacter jejuni. So Salmonella, Shigella, Campylobacter, Vibrio. Vibrio cholerae. So use it for the treatment of those. Okay, that's infectious diarrhea. You can, of course, use it to manage STDs. And the STDs here would basically be chancroid, you know, and chlamydial infections. So chancroid, that is Haemophilus ducreyi, and chlamydial infections. It is just effective against, again, chlamydia trachomatis infections. And we've already seen which ones those are. So STD, you can use it also to treat sometimes skin and soft tissue infections, you know. And then of course eye and ear infections. We've seen the different preparations. You know, chlamydia can cause that trachoma, can cause that inclusion conjunctivitis. And even when you have what some people call swimmer's ear, you know, when you're swimming, you can use Cipro, or when you have that redness in the eye, you know. So you can also use it to treat such conditions. It is effective against rickettsia, but you don't often see it used to treat typhus. You know, technically it should be effective in the management of typhus because it's effective against rickettsia. But you don't see that too often in the treatment. Now, otitis media, because of this Branhamilla, you know, Branhamilla catarrhalis can cause otitis media. So you can use it there. Neisseria gonorrhea, no, it's been ruled out. You know, technically, or the prevailing notion now is that it will not work in Neisseria, again because of the development of resistance to your Cipro. In this situation, the resistance develops either because of an active efflux of the drug, so the bacterium is just throwing it out, okay? Or number two, a decrease in the permeability of the bacterial membrane. So it's throwing whatever is in out, and it is not allowing new molecules of the drug to come in. That would be another resistance. And then the third mechanism is that the organism can develop a DNA gyrase that would not be responsive, or that would not have affinity for your Cipro. So those are the three mechanisms of resistance of bacteria to Cipro. And all those three have actually been demonstrated in this organism, Neisseria. That's why they say that therapeutically, don't use Cipro for Neisseria species infection. Okay. So those are some of the indications for your infections. We should put in there. We mentioned it earlier, but typhoid caused by Salmonella typhosa. So it's very good for typhus, but not used in It's very good for typhoid, but not used for typhus. Okay. So those are some indications. And to finish it up, can look at the adverse effects. So the adverse effects for your Cipro one, cataracts. or opaque vision. So I'll just say opacity in the eye because of crystals depositing in the eyes. And if those crystals deposit in the renal system, then of course we'll have crystalluria. Okay. So for those two reasons, that's why you advise the patient to take their Cipro with plenty of water to prevent crystals from forming. CVS, cardiovascular system, seldom happens, but if it does, it will mainly be things like arrhythmias, myocardial infarction, and angina. Okay, so angina, myocardial infarction, and arrhythmias. It occurs in less than 0.2% of the population that is using Cipro. Okay, but it can happen. So that's CVS. CNS, that happens frequently. That's one of the top adverse effects of Cipro. So, and it's usually related to CNS stimulation. CNS stimulation. So the patient can feel lightheaded. So lightheadedness, and headaches and dizziness. Yeah, those are CNS related adverse effects. And seizures. So if a patient is epileptic, you should not use Cipro to treat that patient. Yeah. So seizures and all that can occur. Of course, your non-specific GI adverse effects, those nausea, vomiting, diarrhea, and stuff like that can occur. Arthropathy. And I will put tendinitis or tendinopathy. That's better. This is why you say don't use Cipro in the two extremes, the very old or the very young. Okay, the very young, they can have a problem with their joints, that's arthropathy. And the very old would have a problem with their tendons, particularly the Achilles tendon. It can lead to Achilles tendon rupture. That can then lead to, of course, falls and all the things that can happen from that point on. Okay. So that's where the age situation comes in, or consideration. Photosensitivity. So don't expose yourself to too much sunlight. And hypersensitivity. Okay. And then you have the issue of the drug being a wide spectrum agent. So you can get supra infection. And the supra infection, of course, can lead to pseudomembranous colitis. which may be manifested as your Clostridium difficile infections, or you see that Clostridium difficile associated diarrhea. Those can come from there. Then you have one that is usually consequential in diabetic patients because the drug can elevate the plasma levels of glucose. Okay. And all of those have been reported with your Cipro. Okay. Drug-to-drug interactions, and, many of them you can draw from here. One will be with your oral hypoglycemic agents or even with your insulin. So you have to increase the dose of insulin or oral hypoglycemic, or just avoid using Cipro. So you can draw from that one. We talked about the agents that can decrease GI absorption. Okay, so ferrous sulfate and zinc, caraphate, all of those can decrease the GI absorption. Magnesium, calcium, zinc. So all of those will decrease the GI absorption. And we've mentioned the effect on A12. So Cipro can inhibit the metabolism of tegretol, carbamazepine. So that can happen, and Cipro can actually increase the clearance of some drugs. We can, okay, so those are some drug-to-drug interactions that one can see with your Cipro. Okay. I think we can hold it here. To highlight. Oh, I think I put ofloxacin in there under the study guide. Ofloxacin, you can give peel, you can give IV, and you can also administer as an ophthalmic preparation, Ocuflox. Ifloxacin, Ocuflox. The Otic preparation basically was withdrawn by the company itself, because whatever you can put in the eye, you can also put in the ear. So it was like a duplication, but anyway, Ocuflox is still available. For that, ofloxacin. And something stands out about ofloxacin, about two things. One, it gets excreted through the breast milk. So it should be avoided in a patient who is breastfeeding, that Ocuflox. And it also causes a lot of dysgeusia. Taste, altered taste, dysgeusia. So breast milk excretion and that altered taste. Those things are about your ofloxacin. Ofloxacin is administered orally. Actually, it was the very first fluoroquinolone that was made, and it concentrates in the renal system. So it is still used today for urinary tract infections, cystitis, and it also gets into the prostatic fluid. So if you have prostatitis, it is also effective in there. That's ofloxacin. Ofloxacin is just not limited to ophthalmic infections. Ofloxacin. We used to have two preparations there, but Zymid is Zymid has been removed, but Zamaxid is still available. Becifloxacin, that's just for redness in the eye or conjunctivitis. That's becifloxacin. And delafloxacin. Delafloxacin is used now for ABSSSI, acute bacterial, skin and skin structure infections. ABSSSI. That's what that delafloxacin is used for. But now they have included CAP, that is community-acquired pneumonia, into its indications. That's for delafloxacin, and you can give it IV or PO. If you give it IV or PO, it is the same frequency of administration, every 12 hours. Every 12 hours. If you use the IV, you use 300 milligrams. If you use the PO, you use 450 milligrams. Okay, that's delafloxacin. And moxifloxacin, that's the one that we said you can use to treat pneumonic and septic plague. Okay, pneumonic and septic plague. You can administer it orally, and it also has a topical administration. You can administer it as an eye drop. That is that moxifloxacin. It comes in two preparations. One you give every 8 hours. Okay. And the other preparation you give every 12 hours. That's one that's called Vagamot. That is the one that you give every 8 hours. The Moxiva, is supposed to be given every 12 hours. That brand name Moxiva has been removed from the market, but you can still see moxifloxacin that is administered Q12. Okay, so that's for moxifloxacin. Moxifloxacin tends to prolong or increase your QT interval. And so it should not be given concurrently with a class 1A antiarrhythmic agent, because it prolongs the QR interval. And it should not be used when you have a hypokalemic. If you have a hypokalemic condition, you should not use, moxifloxacin, because that would worsen the arrhythmias, because of the hypokalemia. Okay, we can hold it there. Questions? Okay. I have nailed down the schedule, so next Monday we will meet virtually. Okay. So that's when we will discuss antiviral agents. And I've already sent you the study guide for antivirals, and we'll do that online as well, virtually. So somebody needs to set it up. Do it by Zoom or what? Okay, whichever we did the review, so we'll do it that way. Questions? Are your grades posted yet? Yes. Okay. All right. We'll see.